Hi everyone, and in this video we'll be discussing another topic, that is antifungal drugs. Now, can you guess some of the fungal infections? Do we see them regularly in the hospitals? What are the fungal infections which we see regularly in the hospital? They are mainly superficial fungal infections. The tinea, that is Tinea cruris, Tinea barbaria, they are called dermatophytic infections, or the Tinea versicolor. Or you can see the superficial candidiasis, that is the oral candidiasis, the vulvovaginal candidiasis. But what about the systemic or deep mycosis like aspergillosis, mucormycosis, histoplasmosis? Usually we see them in immunocompromised patient or a patient on anti-cancer therapy or a patient is HIV positive. So most commonly what we see this infection in dermatology, systemic infections we see in immunocompromised patients. So let us understand how do we kill this fungus or how do we stop the multiplication of this fungus. So before I begin, there are two important infections to deal: superficial fungal infection and deep fungal infection. We'll come to this slide later. So it's just a introduction for you. What we see superficially is candidiasis, dermatophytic infections, and pityriasis versicolor. Then deep are aspergillus, blastomycosis, then chromoblastomycosis, candidiasis invasive, cryptococcus, and coccidioidomycosis, mucormycosis, histoplasmosis, sporotrichosis, and fusarium and pseudoascheria. Pseudoalasceria. These are the deep fungal infection. Now we'll come to the treatment drug of choice to that later. First of all, let us understand what is the mechanism of action of these antifungal drugs. Antifungal drugs. Now, as we studied the bacteria, we told you how the drugs kill the bacteria, what are the targets. Similarly, here also, we have the same targets to achieve. So, let me write. This is the fungal cell wall. So, this is the fungal cell wall. And inside the cell wall, we have the cell membrane. So, this is the cell membrane. This is the cell membrane of the fungus. Yes. Now, in the fungus, there are certain metabolic process going on. What is that? There is something called squalene. So, squalene will get metabolized and give rise to something called lanosterol. So, the enzyme which convert this is called squalene epoxide. It is called as squalene epoxide. Now, this lanosterol is converted into another thing that is called ergosterol. Now, this ergosterol is required for making cell membrane. Remember, it is required to make cell membrane, and the enzyme which does that job is called 14 alpha demethylase. 14 alpha demethylase. So, similar to the bacteria, also we have the nucleus here, and we also have the mitotic process which occurs inside the fungus also. So, you can interfere with the mitosis, the mitotic process, or the DNA synthesis, or you can interfere with the protein synthesis. So these are the places where you can stop the multiplication of fungus. Now the first target is to target the cell wall. So let us go in a systematic manner. We'll understand the drugs which affect the cell wall. Second, we'll understand the drugs which affect the cell membrane of the fungus. Number 3, we have the drugs which inhibit the conversion of lanosterol to ergosterol, and they are called as azoles. Now we'll discuss them separately. That is the third target. What happens if we inhibit this? The lanosterol will not become ergosterol. If there is no ergosterol, the cell membrane is not properly, and the fungus is becoming weak and it is killed. Now the fourth is to inhibit the squalene epoxide. What happens if we inhibit this? The squalene accumulates and it is toxic to the fungus. Now the fifth you can inhibit is the mitotic spindles, and the drug is called griseofulvin. We'll discuss it shortly. Or you can inhibit the DNA synthesis. The name of the drug is called flucytosine. Or you can inhibit the protein synthesis. and the name is called tavabarol. So we'll discuss these drugs one by one. Let us start our journey. We'll start with the same process, affecting the cell wall, cell membrane, then ergosterol synthesis, then inhibiting squalene epoxide, inhibiting mitotic spindle, inhibiting DNA synthesis and protein synthesis. These are the targets. So let us go one by one and discuss this. So the first drugs what we are going to do, they are going to target the cell wall. Now they inhibit an enzyme called 1,3-beta glucan synthase. Now this is an enzyme which is important to form the cell wall. Now if you inhibit that, the fungal cell wall is not formed and fungus is killed. And the drugs which inhibit that, they are called echinocandins. They are called as echinocandins. So echinocandins are mainly used in two important conditions. They are used in candidiasis. So they are used in candida, that is called glabrata, and Candida krusei. It is also used in Aspergillus infection. So that is the use of echinocandins. So that is a group name, sir. What is the drugs? What are the drugs here? Now the drugs here are, they end with fungin. For example, caspofungin. So it ends with fungin. Very, very important. Caspofungin. We have another drug called anidulafungin. The name is anidulafungin. So the advantage of this is it is safe in both RF, that is renal failure, and hepatic failure, that is liver failure. The reason is it undergoes slow metabolic degradation. Slow metabolic degradation, so it doesn't depend on the renal or the hepatic. So that is one special point about the drug anidulafungin. Again, it ends with fungin. Very, very important. One more drug, again it ends with fungin, is micafungin. So remember as CAM drug, C-A-M, CAM. What is that CAM? Caspofungin, anidulafungin, and micafungin. And in the exam, if they give also, you can remember them as fungin. And what is the site of action? Cell wall. What do they inhibit? 1,3-beta glucan synthase. Yes. So the second target, what we are going to discuss now, these are called as polyene antibiotics. They are called as polyene antibiotics. Polyene antibiotics. So the name is amphotericin B. It is called as amphotericin B, one of the famous drug in pandemic, you all know. Now this is also called as conventional amphotericin B, which is there from so many years. Now apart from that, we have the other one, harmycin and natamycin. These are highly toxic to the kidney, highly nephrotoxic. So if they are highly nephrotoxic, can we use them? Can we use them systemically? No, they are used only topical only. These are approved only for topical. The name is called harmycin and natamycin. Harmycin and natamycin. Most important thing is the amphotericin B. Let us discuss what does it do, what is the mechanism of action in the cell membrane. Now this is the cell wall, and inside there is the cell membrane. This is the cell membrane. Now what happens when we give amphotericin B? Let me write here. The amphotericin B, what we give, enters inside the cell. Now when the amphotericin B enters inside the cell, this amphotericin B will combine with ergosterol. So when it combines ergosterol, this combination will create a pore in the cell membrane. So they will create pores in the cell membrane. So the site of action is cell membrane. They create pores in cell membrane. Now what happens if you create a pore in the cell membrane? What happens? the cellular content will try to come out of the pore, and what happens? The cell will swell and it will rupture. So the cellular component will come out, and this will produce the fungicidal effect. So amphotericin B is a fungicidal agent. It's a fungicidal agent. So it creates the pore. So one of your exam, they'd ask the question, what is the site of action of amphotericin B? Cell membrane. Very, very important. Please mark this. So it creates a cell membrane, that is a major mechanism of action by combining with ergosterol. Now, such a beautiful drug, where to use it? Where to use it? Before I come to the uses, what is the problem with conventional amphotericin B? I'll write the adverse effect. What are the adverse effects we faced with that? Number one, when we give this conventional amphotericin B, patients started having infusion reactions. Now, what do you mean by infusion reaction? When you give a drug IV, there is a chance of chills and rigors. So, patient may develop chills and fever, and that is called infusion reaction. So, it can be avoided by giving slowly or adding antihistamine, that can be done. But the second important problem is the patient started having nephrotoxicity. So the dose limiting toxicity of amphotericin was nephrotoxicity, because I told you when the drugs target cell membrane, there is a chance they also hit our cell membrane. That's why the drugs affecting cell membrane of the bacteria are also going to affect the cell membrane of humans. If they are affecting cell membrane of fungus, there is a chance they also affect us. So the problem with that is the drug can cause renal tubular acidosis and azotemia. So it can cause nephrotoxicity. Number three, it can cause anemia. So the anemia that is seen is called as hypochromic, but it is normocytic anemia. So the anemia what we see with amphotericin B is called hypochromic, but normocytic, cell size is normal. But most important thing is decreases two important ions, the potassium and magnesium. Repeatedly asked in your exam, amphotericin B is known to cause hypokalemia. And number five, seizures can occur if you are using it intrathecal. Seizures can occur if you are using this into the intrathecal area. So these are the things. Remember, main important thing is nephrotoxicity, and one more main important, it decreases potassium. These are the potential questions for your future exams. So the problem is, if the drug comes to the kidney, then on the problem. Now what we do something so that the drug is delivered only to the place where it is required. So then we came with a newer preparation of amphotericin B, which can deliver that to the target site where the fungus is there. So those newer preparations are, what are the newer preparations of amphotericin B? Let me write. Newer preparations of amphotericin B. So the most important one in that is liposomal amphotericin B. It is called as liposomal amphotericin B. What's the advantage, sir? Less adverse effect compared to the classical, that is conventional, and less nephrotoxic potential. So that is the reason why it is preferred nowadays, liposomal amphotericin B. So less infusion reaction, less nephrotoxic, but the problem is cost. So it is a bit costlier. That's it. Otherwise, most of us are using that one. Then we have amphotericin B colloid dispersion. So the ABCD, that is called amphotericin B colloid dispersion. The only problem is it has shown to increase the infusion reactions. Okay, it is also less nephrotoxic, but the infusion reactions are more with this. Then we have the amphotericin B lipid complex. Amphotericin B lipid complex. These are the newer preparation, but mainly for your exam, remember liposomal amphotericin B. Others are A, B, C, D. that is amphotericin B colodispersion. Many a times liposomal amphotericin B is also remembered as LAMB. So LAMB, L for liposomal, AM for amphotericin B, LAMB. Okay, so very good drug. Now where to use this? Uses of liposomal amphotericin B. Now there are two important uses: the fungal infections, the other infection. What is the other infection? The non-fungal. The non-fungal is, it's the drug of choice for one non-fungal condition. What is that? Leishmaniasis. So it is used for visceral leishmaniasis. Visceral leishmaniasis, it's the drug of choice. Not only visceral, even for mucocutaneous leishmaniasis, it's the drug of choice. What is the other name for leishmaniasis? That is visceral. It is also called as Kala Azar. So very important point. Please mark it. Very important. Now coming to the fungal infection, there is one we all came across in pandemic, mucormycosis. So here also the drug of choice is liposomal amphotericin B. Again, another question for you. Okay, mucormycosis. Now, because of the side effect, and we have so many newer drugs available which are more safe, it is reserved for serious systemic fungal infections. So it is a reserved drug for serious systemic fungal infections. So it is reserved for that. So usually what we do for systemic fungal infections, nowadays we have the azole group of drugs. They end with conazole. They are used. If they are not working, then only we use amphotericin B. Otherwise, we use only for the management of mucormycosis, because that is the best drug what we have now. And it is also drug of choice for one more condition, that is called cryptococcal meningitis. Cryptococcal meningitis, it's the drug of choice. So this is again a question for you. Now what is the combination we usually give? What we do in cryptococcal meningitis, we use the LAMB, let me refer it as liposomal amphotericin B, plus or minus flucytosine. So these are given, and after the patient is stabilized, then you can shift the patient to oral fluconazole. Very much important. So why these are preferred? Because these are given IV and they work immediately. Fluconazole can work, but it takes a longer time. So in your exam, if they are given cryptococcal meningitis, what is the drug of choice? It is liposomal amphotericin B. If they are given flucytosine also, you can choose that. Okay, fluconazole is not a drug of choice. It is used for cryptococcal infection, but meningitis, it is liposomal amphotericin B plus or minus flucytosine. Yes. So that is about the drug liposomal amphotericin B. Very important. The next group of drugs, the fourth one, they are called as azoles. Very important drugs. Now what do? I told you lanosterol is converted into the ergosterol, and ergosterol is required for forming what? Cell membrane. Now what is the enzyme which does that job? It is called 14 alpha demethylase, and azoles are the drug which inhibit this. So the cell membrane is not formed properly. Now another important aspect of azoles, these azoles are also enzyme inhibitors. Example is the ketoconazole drug. So let us understand these azoles separately. So let me write these azoles in this manner. The ones which are given topical, the ones which are given systemic. So the ones which are given topical and the ones which are given systemic, and the one which is given both topical as well as systemic. So let me do like this. Now what is the topically used azole group of drugs? The name is called clotrimazole. Now, many a times it's important that you don't confuse clotrimazole with cotrimoxazole. Cotrimoxazole is a antibacterial drug. This is clo. The other drugs are luliconazole, luliconazole. Remember, very important, they end with conazole. Luliconazole, miconazole, then sertaconazole. Sertaconazole has another special property. It has two important properties: antipruritic. So very good, because when there is fungal infection, there will be itching. So it has antipruritic, and one more important point is anti-inflammatory property. Very important. So this was the question important for this. Which antifungal has antipruritic properties? Sertaconazole. Now, what is the one which can be used both? Ketoconazole. Ketoconazole is the one. Now, tell me the ketoconazole story. Ketoconazole is used topical where it is topically used as shampoo for dandruff. Shampoo for dandruff. So it comes as KZ shampoo. And where do you use it? Systemic. Please remember, ketoconazole inhibits steroid synthesis. So where do you give it orally? To treat a condition called Cushing's disease. So Cushing's disease, the steroid synthesis is more, and we want to suppress this because ketoconazole inhibits what? Steroid synthesis. Very important. Steroid synthesis. That is ketoconazole for it. So the problem with ketoconazole is, I told you, azoles are usually microsomal enzyme inhibitors. And one more problem with ketoconazole is it can cause gynecomastia. So one more problem is it can cause gynecomastia. So that is about the drug ketoconazole. Nowadays we are not using it because it's an enzyme inhibitor, gynecomastia, and also it inhibits steroid synthesis. Now we have better drugs than that. What are the better drugs? Systemic antifungals. They are called itraconazole. Now I'll write where it is used later, where it is drug of choice and all. Then fluconazole. Fluconazole. So we have the fluconazole, and we have another important, that is called oriconazole. The name is oriconazole. Oriconazole. Oriconazole has shown an adverse effect, that is patients may develop visual and auditory hallucination. So patient may have visual and auditory hallucination. So remember V for visual hallucination. Then recently two new drugs have come to the market. They are called posaconazole. The name is posaconazole. What is the name? Posaconazole. And one more is isavuconazole. Isavuconazole. And if you read their name, they all end with conazole. Please understand, these are also useful in treating a condition called mucormycosis. They are used for mucormycosis, but they are not the drug of choice. The drug of choice is liposomal amphotericin B, but the alternative drugs are posaconazole and isavuconazole. Sir, won't itraconazole, fluconazole, voriconazole act on mucormycosis? No, they don't have any activity. They don't work on that. And they can ask in the exam, sir, will fluconazole work on Candida krusei? It will not work on Candida krusei because it has something called intrinsic resistance. Intrinsic resistance means it is natural resistant for the fluconazole. This is the question that can come. It is not going to work on Candida krusei. So that is about the azole group of antifungal drugs. Okay, so we are done with the fourth target. Okay, so the next target what we are going to discuss is the inhibitor of an enzyme called squalene epoxide. So the next target is to inhibit the enzyme called squalene epoxide. So what is the drug which inhibits squalene epoxide? The name is called terbinafine, and one more is called butanafine. So we have terbinafine and butanafine, and these are used to treat mainly dermatophytic infections. So they are used mainly to treat dermatophytic infections. Now the next target what we have is the one which inhibit mitosis, and the drug is called griseofulvin. It is called as griseofulvin. Now how the griseofulvin works? It inhibits the microtubule polymerization. Now you can ask a question, what is the problem here? The problem is when you inhibit microtubule polymerization, the cell division will not occur, the mitosis is interrupted. So when the mitosis is interrupted, the fungal cells will not multiply. So the mechanism is by inhibiting microtubule polymerization, that is griseofulvin 5. Now this is given orally in the treatment of mainly dermatophytic infection, dermatophytes. Now the specialty of it is when we give it, it will go and inhibit the fungus wherever there is keratin is rich. It is getting attracted to that. So mainly keratin is rich in the skin, the nail and hair. So there it will go and it will prevent the multiplication of fungus, and that's why it is used orally for the dermatophytics. And also it is used in tinea capitis, one of the beautiful drug for that. Now another important thing is, can we apply that topically? Remember, it is not effective topical. Not effective topical. So that is about griseofulvin. But whenever we think of griseofulvin, there are some special point regarding the pharmacokinetics. Remember, it's a enzyme inducer. It's an enzyme inducer, that is first point. Second, if it is consumed with alcohol, it is known to produce disulfiram reaction. Disulfiram reaction. Can you guess one more drug which is used in protozoal infection and cause disulfiram? Yes, if you're thinking metronidazole, you are correct. Then, if this is taken with fatty food increase the absorption of this drug. That is griseofulvin. Now we are done with the next target. The next target is to inhibit the DNA synthesis. To inhibit DNA synthesis. And what is the drug name? The name is called flucytosine. So flucytosine, here also we are giving a fake nucleotide. So we are giving a fake purine or pyrimidine here. Now this flucytosine, after going into the fungus, it will become 5-fluorouracil. I think you have heard of this already somewhere. 5-fluorouracil has anti-cancer property, and this will inhibit the DNA synthesis. Now this is not converted in human cells, that is flucytosine into 5-fluorouracil. That's why the normal human cells are not affected. Only the fungal cells are affected. And this is a fungistatic drug. Now where do you majorly use this? It is majorly used in managing cryptococcal meningitis. Cryptococcal meningitis it is used. So it is used in meningitis, that is cryptococcal meningitis, along with amphotericin B. What is the adverse effect of the drug? Since it can also enter our cells and get activated, there is a chance of bone marrow suppression. So there is a chance of bone marrow suppression, and most important, you should decrease the dose in a patient with renal failure. Renal failure. So these are the points. So simply remember, flucytosine can become 5-fluorouracil and inhibit the fungal DNA synthesis. It is used in cryptococcal meningitis. Why bone marrow suppression? Because our cells can also convert that flucytosine into 5-fluorouracil. Very less chances, but if they convert, there is a chance of bone marrow suppression. Now, another important one is the inhibition of protein synthesis. How does it inhibit? It inhibits the tRNA synthase. By inhibiting tRNA synthase, it inhibits the protein synthesis. So, what is the drug I am talking about? The drug what I am talking about is called as it is called tavabarol. So it is called tavabarol. It is mainly approved for treating toenail fungal infection. Toenail fungal infection. Now, one more drug that is approved for toenail fungal infection. Why I am repeating this? Because toenail fungal infections are not going to go away easily. So it requires treatment very long period, up to 1 year. One more drug that is called efinaconazole. These are two drugs which are used in the toenail onychomycosis. New drugs. They are new drugs and they can be a potential question for your future exam. So these are the drugs what are used as antifungal drugs. Now another one minor mechanism is a drug which inhibits the chitin synthesis. Chitin synthesis, and the name of the drug is called nicomycin. Nicomycin, again this is used to treat the dermatophytic infection, dermatophytosis. Right. So until now, I have done with the different antifungal mechanism and different drugs. Let me summarize the things here. Most of the exam question is on mechanism of action. The drugs inhibit the cell wall. They are echinocandins. They inhibit 1,3-beta glucan synthase. The cell membrane permeability is increased by amphotericin B. The azoles inhibit 14-alpha demethylase. Thereby, they decrease the ergosterol synthesis. The inhibitor of squalene epoxide, they are terbinafine, then butanafine. They are going to increase cholesterol level. They are going to increase the squalene level, and the squalene is toxic to the fungus. The inhibitor of mitosis is called griseofulvin, and the inhibitor of DNA synthesis is called flucytosine, and the protein synthesis inhibitor is called tavabarol. So this is the mechanism of action in brief. And please concentrate on the adverse effect of amphotericin B. Very, very important. So once we are done with this, it's important that we know what are the antifungal drugs used topically. And this will be discussed in dermatology also. Now, if you know in forehand also, it's very easier when the lectures of dermatology is, when you see those lectures, it will be easier for you. So what are the drugs? We have the polyenes. So what are the polyenes we have? They are called harmycin, then natamycin, and nystatin. These are given as topical. Then we have azoles, which are given topical. Yes, you already know them. Clotrimazole, then luliconazole, then miconazole, then sertaconazole, then efinaconazole. So once we know this, there is one more category of drugs. They are called the butanafine, they are called allylamines and terbinafine. The other category of drugs which are used topically are, let me tell you here, it is called as the Whitefield's ointment. Whitefield's ointment is extensively used. It is a combination of two things, salicylic acid plus benzoic acid. It's a combination of salicylic acid and benzoic acid. That is Whitefield's ointment. Another one is called cyclopyroxolamine. Then we have andecyclinic acid. And then we have tolaftate. So these are the topical antifungals what we use in treatment of the fungal infections. So once I know this, it's important we know the drug of choices for certain conditions. So we'll take that and discuss it. Okay, we'll start from here. So once we know the fungal infection, I told you there are superficial and deep fungal infections. Now for superficial fungal infections, candidiasis, dermatophytosis or pityriasis versicolor, what we prefer is the commonly used drugs are, we can give the fluconazole, itraconazole or terbinafine. These are given orally, usually in the dermatology department. So these are the oral drugs to treat the candidiasis, dermatophytosis and pityriasis versicolor. Now for all these, we can also use the topical antifungals. Just now we discussed that the topical antifungals can be used. So you can use them to treat candidiasis, dermatophytosis and pityriasis versicolor. And one more drug that is exclusively used for dermatophytosis, the name is called griseofulvin. So this is how we manage in dermatology the superficial fungal infection. Now if you come to the deep mycotic infections, very much important, the management of deep mycotic infection. So Aspergillus, two important conditions is the allergic one, allergic bronchopulmonary aspergillosis, allergic bronchopulmonary aspergillosis. As the name suggests, it's allergic. So for allergic phenomenon, what is better? For allergic phenomenon, what we can give is steroids. Now if I give steroids only, you know that they are immunosuppressant. Along with that, we add itraconazole for that. So that is the treatment of choice for allergic. The second one is invasive aspergillosis. If it is invasive, then what is the treatment of choice? The treatment of choice for invasive would be voriconazole. So it is called as voriconazole. So this is very, very important. They keep on asking this question again and again. What is the treatment of choice for the invasive aspergillosis? Remember, A, aspergillosis, the treatment is B, voriconazole, that is invasive one. What about blastomycosis and chromoblastomycosis? For both, the drug of choice is itraconazole. It is the itraconazole, right? And any candidiasis, cryptococcosis, coccidioidomycosis, for all these three C's, you can see the C here, all the three C's, the best drug is fluconazole. Fluconazole is the best one. So if it is not there in the option, then only you can go for itraconazole, but the best one is fluconazole for all the three. Now suppose the patient is having cryptococcal meningitis. Then what is the treatment? I told you already. Let us just revise this. It is nothing but the liposomal amphotericin B plus flucytosine. So once the patient is stabilized, then we can put the patient on oral fluconazole. Very, very important thing. So then we are moving on to the next one, the mucormycosis, which we faced in the pandemic. The drug of choice is liposomal amphotericin B, LAMB. What are the alternative therapies for that? Yes, can you tell me what are the alternative therapies? You know it. They are the posaconazole and one more is called the isavuconazole. These are the alternatives. Histoplasmosis and sporotrichosis, the drug of choice is itraconazole. In the management of fusarium and pseudolisteria, it is the voriconazole. So this table is very, very important. The fungal infection and the drug of choice, very, very important. Aspergillus, allergic, it is steroids plus itraconazole. Invasive vori, any blastomycosis is itra. Anything starting with C, usually it is fluconazole. Mucormycosis, liposomal amphotericin B. Histoplasmosis, porotrichosis, again itraconazole. Fusarium and pseudoalasteria, it is voriconazole. Remember, Nowadays, amphotericin B is replaced, except in mucormycosis, we are using azoles. But many a times azoles may not work, then we go for again liposomal amphotericin B. That's why I told you it is a reserved drug for serious systemic fungal infection. But for superficial, you can give oral drugs like fluconazole, itraconazole, or terbinafine for dermatophytosis, or you can apply topically. We discussed topical antifungal drugs, and grisophulvin is mainly used for only the dermatophytic infection. So that is about antifungal drug. Mainly, you have to concentrate on importantly mechanism of action, the cell wall, cell membrane, then azoles, 14 alpha demethylase, then squalene epoxide, the mitosis, DNA synthesis, and protein synthesis. Now, once you are done with that, adverse effect of amphotericin B, and then what are the fungal infection, what are the drug of choice. These are the important things what you have to concentrate when you revise it. Thank you all.